name is Dr. Laurena Law, a practicing medical doctor with an interest in women's hormones. Today, I want to talk about something that affects so many women, yet is often misunderstood or dismissed: premenstrual syndrome, or PMS, and its more severe form, premenstrual dysphoric disorder, or PMDD. If you've ever felt that the week or two before your period is a monthly struggle with difficult physical and emotional symptoms, please know you're not alone, and what you're experiencing is very real. It's not just being moody. In this video, we'll explore what PMS and PMDD are, why they happen, and most importantly, what you can do to find relief. Let's get started. So what exactly is premenstrual syndrome? PMS is a group of physical and emotional symptoms that consistently occur in the second half of the menstrual cycle. The key thing is that these symptoms tend to start about a week before your period and go away shortly after your period begins. It's incredibly common. In fact, up to 75% of women with regular cycles experience some form of PMS. The symptoms can be both physical and emotional. Physically, you might experience bloating, breast tenderness or swelling, headaches, and a deep sense of fatigue. Emotionally, it's common to feel more irritable or angry, anxious and worried, sad or tearful, and have noticeable mood swings. For a diagnosis of PMS, these symptoms must be present before your period and resolve afterwards, and they must include a mix of both physical and or mood-related changes and interfere with functioning. Now let's talk about premenstrual dysphoric disorder, or PMDD. You can think of PMDD as a severe form of PMS. While it's much less common, affecting about 3 to 8% of women, its impact can be profound. The American Psychiatric Association and the ACOG uses the DSM-5 criteria to diagnose PMDD. For diagnosis, at least 5 symptoms must be present in the final week before menses and improve within a few days after the onset of menses and become minimal or absent in the week post-menses. 1 or more symptoms in section B and C must be present and reach a combined total of 5 symptoms. Section B symptoms include: number 1, marked affective lability. So for example, mood swings, feeling suddenly sad or tearful, or increased sensitivity to rejection. Number 2, marked irritability or anger, or increased interpersonal conflicts. Number 3, marked depressed mood, feelings of hopelessness, or self-deprecating thoughts. Number 4, marked anxiety, tension, or feelings of being keyed up or on edge. Section C symptoms include: number 1, decreased interest in usual activities, for example, work, school, friends, and hobbies. Number 2, subjective difficulty in concentration. Number 3, lethargy, easy fatigability, or marked lack of energy. Number 4, marked change in appetite, overeating, or specific food cravings. Number 5, hypersomnia or insomnia. Number 6, a sense of being overwhelmed or out of control. Number 7, physical symptoms such as breast tenderness or swelling, joint or muscle pain, a sensation of bloating or weight gain. The defining feature of PMDD is that symptoms are severe enough to cause serious problems in your daily life. This could mean having major conflicts in your relationships with family and friends, or finding it difficult to function at work or school. It's a chronic condition that can seriously affect your quality of life. It's not just a bad mood, it's a debilitating medical condition that deserves care and attention. A common question I hear is, why is this happening to me? It's important to understand that this is not all in your head. There is a real biological reason for these symptoms. While the exact cause isn't fully known, doctors believe it's related to how your brain reacts to the normal hormonal fluctuations of your menstrual cycle. After you ovulate, your levels of estrogen and progesterone rise and then fall before your period. In women with PMS and PMDD, it seems that their brains are particularly sensitive to these hormonal shifts. This sensitivity can affect neurotransmitters like serotonin, which is a chemical in your brain that helps regulate your mood. Interestingly, studies show that women with and without PMDD have the same hormone levels. The difference lies in the body's response to them. So it's not a hormone imbalance, but rather a unique sensitivity to normal changes. If your premenstrual symptoms are negatively impacting your life, it's time to talk to a healthcare provider. A crucial first step in getting a diagnosis is to track your symptoms. To do this, you can use a tool called the Daily Record of Severity of Problems, or DRSP. I recommend patients fill this out every day for at least 2 full menstrual cycles. This chart helps you and your doctor see the pattern clearly, that your symptoms appear in the week or 2 before your period and disappear once it starts. This is the most important step to distinguish PMS or PMDD from other conditions like depression or anxiety, where symptoms are usually present all month long. And a very important note, If you ever have suicidal thoughts or thoughts of self-harm, please seek help immediately. This can be a symptom of severe PMDD and it's a medical emergency. The good news is that there are many effective treatments available and you don't have to suffer through this every month. The approach is always personalized to your specific symptoms and their severity. Let's start with lifestyle modifications. Regular exercise, even gentle walking, has been shown to help reduce stress, anxiety, and depression. Relaxation techniques like yoga or mindfulness-based meditation can also be very beneficial. For menstrual pain symptoms, non-steroidal anti-inflammatory drugs can reduce abdominal cramps, headaches, and general body aches. Common side effects include nausea and indigestion, so taking NSAIDs with foods is recommended. For moderate to severe symptoms, especially with PMDD, the most effective and first-line medical treatment are a class of medications called SSRIs, or selective serotonin reuptake inhibitors. These are antidepressants that help correct serotonin neurotransmission in the brain. They can be taken every day, or in some cases, just during the second half of your cycle. Studies show that 60 to 75% of women with PMDD find significant relief with SSRIs. Another option can be certain types of combined oral contraceptives or birth control pills. Some formulations, particularly one containing drospirenone, are approved for treating PMDD and can help by regulating hormonal fluctuations. There is a gap in research around PMS and PMDD during the menopause transition. With fluctuating levels of estrogen and progesterone during the menopause transition, there is an increased risk of depression by 1.5 to 2.9 times. Several studies have shown the use of menopause hormone therapy can be effective treatment for perimenopausal depression, and more research is needed. For non-pharmacological therapy, CBT or cognitive behavioral therapy is recommended for mood symptoms. This is a type of therapy that can help reframe negative and irrational thought patterns and often include education on relaxation techniques, problem-solving skills, and stress management. It is the most studied psychosocial intervention for the management of PMS. Online-based CBT are also effective and can help reduce treatment barriers. Calcium supplementation may improve PMS, but the data is limited. It appears low risk when intake remains within 1,000 to 1,200 milligrams per day and can be considered as part of a holistic approach to management of PMS in adults. Acupuncture may improve physical and mood symptoms, but the quality of evidence is low. It has a low risk of harm and would be reasonable to include it as part of a holistic approach. Vitis acnes castus, also known as chasteberry, has been studied as a herbal remedy for PMS. The mechanism of action is unclear, and the evidence from RCTs is low to moderate quality, so no definitive recommendations can be made for its use in PMS management. For very severe and treatment-resistant cases in adults, other options exist. These include GnRH agonists with add-back estrogen progestin, which aims to suppress ovulation. This is a very effective treatment, but is reserved for when other options haven't worked. And as an absolute last resort, surgery to remove the ovaries can be considered. It's about finding what works for you. Living with PMS or PMDD does not have to be debilitating. These are real, treatable medical conditions, and you deserve evidence-based, personalized strategies. If anything we've discussed today resonates with you, I strongly encourage you to speak with your healthcare provider. Download the patient handout and copy of the DRSP symptom tracking chart so you can start charting your symptoms. Start that conversation and start the journey to feeling better.